to present the data that for my study, or for what is new in new insulins and new injectable therapy. I now have the pleasure to share with you one of the important new studies. Now, obviously, when we are doing the risk calculation nowadays, we need to think of the medication as well. They provide an important aspect in the risk scoring. We know from previous data that patients on insulin have a higher risk of hypoglycemia during Ramadan, and indeed out of Ramadan as well. And we know from the study that Dr. Khadija presented, which we conducted in our center in Dubai, there is a difference between basal insulin and intensive therapy of insulin with mixed insulin or basal bolus, whether in the number of hypos or hypo duration. So with all that in mind, when we have the offer of the different options of treatment in front of us, we would like to choose therapy that would be effective, but also would minimize the risk of hypoglycemia. And now I will present with you some of the data on the GLP-1s. We have shared before and presented in the guidelines some of the previous studies on exenatide as well as on liraglutide. And also we have published previously in 2019 the study of adding lixexenatide to basal insulin in comparison with sulfonylurea in a randomized fashion, which showed that a reduction in hypoglycemic trends. With data on GLP-1 in general from the guidelines, we know that GLP-1s are an effective tool, they have low risk of hypoglycemia, and also they can help to reduce weight. So the question really is about how can we combine them with insulin. The data from insulin, we had some studies in 2007, which showed that basal analogs, glargine was better than others. And also we have, as Dr. Khadija presented, the Orion study on glargine 300. So some basal insulin could be quite helpful. When you go to the risk calculator, you obviously come across the issues of hypoglycemia, about the level of glycemic control. So clearly we want to minimize hypos and improve glycemic control. But in choosing the therapy, we could end up with perhaps a higher score for certain types of therapy. You notice here that basal insulin carries the lowest level of risk score for insulins, and that GLP-1s do not score anything because of their profile and their pharmacodynamics, along with many other drugs as well. So in the SoliRam trial, which I'm really thankful for all the investigators here, including our co-chair, Professor Akif Bukbeish, Dr. Rashid Malik, Professor Ines Shaltud, Dr. Rakesh Sahai from India, my colleagues from Sanofi, the sponsor for the study, Khair Jaballah, Valerie Pilorjay, and Pascaline Picard, as well as Dr. Saud Sifri from Saudi Arabia, our colleague who we all know well. So the objective of this study was to simply look into the fixed ratio combination. When you have both elements in one injection, a basal insulin such as glargine and a GLP-1 such as lixexenatide, on how will that perform to get us to the balance of improving glycemic control while at the same time not significantly increasing hypoglycemia. So this design of the study was a multi-center, multinational, prospective, non-intervention study, a single-arm real-world observational study, which was conducted over 2 consecutive Ramadans, 2020 and 2021. I am delighted that this is the first time for this data to be presented for the public. And it's a power of the conference itself and the power of the data itself. So the population of the study were all tested for 1 to 3 months before Ramadan. We wanted people who are already on the fixed ratio combination of insulin glargine along with lixexenatide for a minimum of 3 months. And then we looked also into what happened during the month of Ramadan and then post-Ramadan. The adjustment of the dose was down to the investigators, guided by the Dar guidelines that were available at the time. The primary objective was to look into, number one, the main point is hypoglycemia. How many had at least one documented and or severe symptomatic hypoglycemic event in the period of pre-Ramadan, Ramadan, and post-Ramadan? Now, the study included 420 people from many countries in the Middle East, as well as the Far East, as well as the Indian subcontinent. And we here look into the baseline characteristics of our patients. Requiring such a type of therapy, well, means that the patients are in their 50s, mean age was 57. The split of gender was 45%, mainly with females. And indeed, they were obese with a BMI of 30.9, indicating that they would benefit from adding a GLP-1. Duration of diabetes was as a mean of 12 years, and over 10 years, it was nearly 60%, to be precise, 58%. The number of patients who were on the Iglar-Nixi, who were insulin naive, were 42%, and some of them were previously on insulin and got changed to the current type of treatment. Now, obviously, the vast majority were on other therapy as well. That's nearly 85%. The mean HbA1c was 8.2, and the fasting plasma glucose was 140. What type of other therapy they were on? As you can see, we had all different types of split. The vast majority were on metformin, followed by sulfonylurea, and the third option was SGLT2 inhibitors. Of course, because of the nature of the study, we were selecting patients who were not on another incretin, so DP4 inhibitors were the only exception of one or two patients which got, of course, removed afterwards. Now, it is important to remember that the vast majority of our patients were injecting in the evening. A small minority, about 11%, were injecting at suhoor time. We do not have a strong recommendation of when. Logic sense means it would be given at the time of the biggest meal. But some people have a bigger meal in suhoor, so maybe that's what they preferred. The adjustment to the other therapy was really quite minimal throughout the study. So how did the type of therapy help people to fast? After all, we've heard throughout the conference about the passion of people fasting. And as you can see here, 93% fasted the full month of 29 to 30 days, according to where you were globally and whether it was 29 or 30 days. Another 3.7% fasted over 25 days. So overall, the 97% nearly were able to fast 25 days or more. The average fasting was 28.8 days, really quite high. And as you can see here from the chart, is 92.4% did not break their fast at all during the study. It is important to remember that the 7.6% of the participants who broke their fast, many of them was not really because of diabetes-related issues, such as travel, pre-existing condition, adverse events. Only 4 were, or 12.9%, of those who broke their fast, not 12.9% of the study, no, 12.9% of those who broke their fast were because of hypoglycemia. Come to the results of the study, the big important points, and look first into the light blue. This is hypoglycemia, documented hypoglycemia, symptomatic and or severe during the month pre-Ramadan, Shawwal month, Sha'ban month. And then that's 1%. During Ramadan, with people fasting for 15, 16 hours and doing their normal lifestyle, only 9 patients had experienced hypoglycemia, which constitute 2.3%. Post-Ramadan, this went down to 0.3. Only 1 person out of those who completed the study did report hypoglycemia. The majority of the hypoglycemia were during the fasting hours, as we'd expect, but there was a sizable proportion during 0.5% during the eating hours. So when we look into the more severe incidence of hypoglycemia with a blood glucose level of below 54 milligrams per DL or 3 millimoles per liter, symptomatic and or severe hypo, that was only 2 patients out of 394, constituting 0.5%. And that was during the fasting hours. And the good thing also, it's showing us the tolerability of such a fixed ratio combination out of Ramadan. That level of hypoglycemia was only experienced by 1 person out of Ramadan and none after Ramadan. So it does look like being involved in the study, checking frequently, getting the attention has made the post-Ramadan experience even better than before. Now, we don't want hypoglycemia with poor glycemic control. And I'm delighted to see that even in such a short duration of the study and without significant change in dose, the HbA1c improved from 8.2% to 7.5%, a reduction of 0.75%, and equally more of the patients were able to get into the glycemic target that we would like for the vast majority of our patients below 7. Although obviously with such an age group and many of them being of the older age as well as being in Ramadan, I would be happy for 7.5 for the majority of my patients. Fasting plasma glucose equally significantly improved by 18 milligrams per DL, and weight also improved by 1 kilogram, ranging from 0.8 to 1.2 kilograms. We know, of course, that GLP-1s are helpful, and we know that some people lose weight in Ramadan, so such a therapy helped them to achieve what they want. Adverse events were quite minimal, and that was primarily the very small number, 0.9% of the participants with the gastrointestinal adverse events. Otherwise, there was hardly any notable adverse events. So, in conclusion, it is important to see from this simple, well-structured, observational perspective real-world study that for adults of the study who were, as I mentioned, in the upper range of their 50s, and many of them had long duration of diabetes, that 90% of them who were treated were able to fast the whole month of Ramadan. That's what the patient wants. But they want to do this with minimal hypoglycemia and with sustaining or improving their glycemic control. And we saw that because the amount of hypoglycemia documented or severe was only 2.3% during the month of Ramadan, despite being on an injectable therapy, including glargine and lixoxenatide. There was no severe hypoglycemia, and as I mentioned, there was hardly any adjustment of therapy during the study, and with good glycemic control. So I sincerely would like to acknowledge all my colleagues. These are my disclosures. I've been, as you have probably heard me several times, in a number of educational activities sponsored by different pharmaceutical industry. But what I want really to share with you is the acknowledgement for the investigators from all the countries that took place across the duration of the study. We are really grateful for them. Without them, the study would not have existed. Thank you all.